Hello everybody. My name is Dr. Priti Anand, and I'll be sharing with you our RRR series for MRCG Part 2 students. And my topic for today is General Gynae. So let's see some very important concept-based questions related to this. Stay focused and never give up. So this is the case where you have to first of all see the lead statement. That was the most likely diagnosis in this case. So you can see the options, all are the diagnostic, basically the options. So what do you diagnose? What this condition, what is the patient suffering from? So 16-year-old girl who has been evaluated for the absence of onset of menses, that is primary amenorrhea, no further medical condition and takes no medication. She is not sexually active. Breast has 10R stage 1. Pubic hair has 10R stage 2. Per abdominal normal. Vaginal inspection normal. Per rectal, you can feel the uterus. Her serum FSH levels are elevated. So this patient, if you see very clearly with regard to primary amenorrhea, if the patient has uterus, that means that part is okay. So outflow tract obstruction may be not a problem because vaginal inspection is also normal. But according to her age, her breast and pubic hair development is not adequate because it has to be 4 or 5 according to the 10R stage, according to the age of the female. So what to do? This patient where FSH levels are elevated, there is some problem with respect to the ovaries. That means ovaries are not functioning properly. However, it is very rare, but yes, it can be, according to the condition, what it says, it is the case of the premature ovarian failure. None of these cases, apart from premature ovarian failure, will have this type of presentation. For example, in androgen insensitivity syndrome, they are perfect females. They will only have absence of pubic or axillary hairs, but their breast development is normal. Congenital adrenal hyperplasia also, usually they have normal breast development and hair and pubic hair is all normal. Imperforate hymen will have pathologies related to the vaginal inspection. And as we go on, we can see that every other presentation, every other condition will have a different presentation than this. Sarah Jones, 17 years old girl, brought for evaluation for primary amenorrhea, indicates she has experienced a growth spurt at the age of 11, which is normal. Breast and pubic hair development began 5 years ago. She has no other medical condition, takes no medication. She is sexually active. There is no history of cyclical abdominal pain. Breast and pubic hair are 10R stage 5. She appears to be appropriate for height. Per abdominal normal, local normal, per rectal uterus weld. Investigation shows primary amenorrhea, but the LH and FSH are very low. Prolactin is very high, estradiol is very high, and progesterone is also high. So I think you can make out from the presentation, everything is normal. Only thing she did not have onset of menses and she is sexually active. And the hormonal profile of this patient tells us that she is pregnant. Okay. None of these conditions other than that, like, for example, if you get confused between why it is not transvaginal septum, then the patient will have cyclical pain on local examination. There will be bulging vagina, pink bulge will be seen, and the hormonal profile will be normal, not like that. Okay. So again, a very typical case, but very important. So primary amenorrhea, how we diagnose is on the basis of secondary sexual characters. If they are present, that means there's a uterus problem, do an ultrasound. If they are not present, then there is a hormonal problem, do the hormone analysis. Okay. So these are some tables which are related to how you can differentiate each one of them. MRKS, CAH, AIS, premature ovarian insufficiency, Sware and Turner syndrome. And the list goes on with the LH receptor defect and Sware also. Okay. So just have a look whenever you are reading. 10R stage, you should have an idea, guys, because sometimes they now give that the patient is 10R stage 1, 2, 3, 4. So you should know which age group has which type of 10R staging. Okay, so next question, they say that what is the most appropriate treatment option for this patient? So all are treatment options, which is the most appropriate for them. So 32-year lady, Jehovah's Witness, menorrhagia, listlessness for 18 months, very weak because of menorrhagia, 3 normal vaginal deliveries. Last one, she got sterilized also. Periods are always heavy. She suffers giddiness, has to take time off for work. On examination, she is pale, otherwise healthy. There is no abdominal mass extending to the pelvis. That means the uterus is not more than 20 weeks. She's irregular. The uterus is irregular and firm in consistency, confirms the presence of multiple fibroids which are intramural, and the ovaries are normal. Now, this patient uh, basically is somebody in whom I think they forgot to mention that medical management they have tried. Okay. If they have tried all medical management and now she becomes a candidate that where the medical management is not helping her, definitely I completely agree there should be mention of that. Medical management, all medical managements has been done, but it's not helping her. All medical management failed. Okay. So this patient is a Jehovah Witness, first condition. And the second condition, she is very young to get a hysterectomy done. Once you do a hysterectomy, it will also compromise her ovarian functions, right? So such patients in whom you have to do something which is minimally invasive, and because their HMB is related to the fibroid, they are the ideal candidates to get the uterine artery embolization to be done. Okay. Uh, Please understand the concept that, look, if it is a multiple fibroids, myomectomy will not help her, and all of them are intramural. Hysterectomy, according to her age, better to be avoided. Now, only thing which can help her is basically a uterine artery embolization, because it is a fibroid which is causing these bleeding, and medical management has not helped her. 39-year-old lady with HMB from last 12 months. She's mother of three, has a husband has got vasectomy done. She's informed that during her third pregnancy 6 years ago, she has fibroid. She noticed that suddenly from few days, her abdomen is getting bigger and bigger and now struggling to fit into her dresses. She do not want to lose her uterus. Physical examination reveals large uterus, which is 24 weeks gestation, multiple fibroids. She sent for ultrasound scan, which shows 10 multiple fibroids. Largest one is very big, 70 into 75 millimeter, lying in the submucosal area of the posterior uterine wall, and she has been placed on GnRH agonist, definitely to make sure her hemoglobin becomes better, but are not able to control her heavy menses. So basically, in nutshell, we can say the medical management is not helping her. There is a big uterus and the big fibroids are there. Now you have to do something as a definitive procedure to help her. Now she wants to retain the uterus, so I will do a myomectomy in this case. The second important question is, what type of myomectomy do I want to do? Laparoscopic or open? Can you read in this question that suddenly it started increasing? The abdomen size started increasing suddenly. So this puts us at query that might be myoma, can be a sarcoma. Okay, it is a suspicion. So during laparoscopy, morcellation is usually done to deliver out the myomas, which is ideally not a good procedure if you suspect something can be cancerous. Okay, so considering that, this patient will undergo the myomectomy, but an open variety. 55-year-old lady with a gradual distension of abdomen from the last 6 months. On ultrasound, there is a large multilocular ovarian cyst on the left side. Tumor markers were reported CA-125, 190, CEA 1.9, and CA 19.9 international unit per ml. So we have to see the most appropriate next step in management for this patient. Now, postmenopausal ovarian cyst, which is big enough, large means it is quite big, multilocular, and CA-125 very high. So if I calculate the RMI score, it is going to be more than 200. So this patient usually will have a RMI of more than 200, where first step in management usually is the referral with the CT scan. Okay, most appropriately, first step, what she requires first thing is the CT scan. Okay, CT scan with the ongoing referral to the gyne-oncologist, which will be doing after discussion. They will be doing the surgical staging. Okay, so the CT scan is the first thing. Referral definitely is required to the onco center, but with the CT scan. So if you have both the options, go for the CT scan as a first option. Okay, most appropriate for this patient is first to do a CT scan. 54 years old lady, USG was done 6 months ago, which showed a simple left ovarian cyst, 5 into 6 centimeters, CA-125 8. Today, after 6 months, means already there has been elapsed after 6 months. That means she was put on follow-up. The cyst is of the same size and CA-125 is also almost the same. Now, any cyst, ovarian cyst, postmenopausal ovarian cyst, which is 5 or more than 5 centimeters, which is more than 5 centimeters in size, as a first instance only, even if the RMI is less than 200, requires a surgery. Okay. So this patient would have been treated in the last appointment itself because the ovarian cyst was more than 5. But now, because she has come after 6 months with the same findings, our duty is to correct our mistake and treat her. And this case, the treatment is not removal of one cyst, the one ovary. It is always a bilateral salpingo-oophorectomy. 36 years old lady with the weight loss and abdominal pain, ovarian mass with the thick septations and focal thickening with solid component. Because it is a complex cyst, so the next step most appropriate is to do the GCT tumor markers. So postmenopausal ovarian cyst, if it is 1 or more than 1 centimeter, do a CA-125, calculate an RMI. If it is more than 200 or equal to 200, CT scan with ongoing referral to the gynecologist at the cancer center should be done. If it is less than 200 and the cyst is asymptomatic, simple, less than 5 centimeter, unilocular or unilateral, put her on follow-up with the conservative management. But if the cyst is more than 5, patient is symptomatic, it's non-simple features, multilocular and bilateral, you put definitely offer this patient bilateral salpingo-oophorectomy. Okay. So this is again another set of questions which is related to endometrial hyperplasia, and we have to tell the single most appropriate management option from the list. So you can see they all are management options. So let's see that 45-year-old lady having irregular heavy menstrual bleeding with endometrial biopsy confirms endometrial hyperplasia without atypia. She was having a normal BMI. Past history has laparoscopic sterilization. LNG-IUS is inserted for 6 months, after which point it was removed. And endometrial biopsy was normal. Subsequent biopsy 6 months later was also normal. That means 2 biopsies were normal. Patient continues to have ongoing bleeding. What is the appropriate management? Please remember, any patient of endometrial hyperplasia without atypia, even if the endometrial biopsies are normal and LNG-IUS has worked, but if she has an ongoing bleeding, she's a candidate for hysterectomy. Okay, so this patient will undergo the hysterectomy. So any patient with progression, no regression, relapse, persistent bleeding symptoms, or decline surveillance are the candidates for hysterectomy. For postmenopausal ladies, the hysterectomy done in these cases will be not only hysterectomy, it will be bilateral salpingo-oophorectomy. Because she's premenopausal, with hysterectomy, you will be doing a bilateral salpingectomy. 42 years old lady, para 3, diagnosed with endometrial hyperplasia with atypia. Oral progesterone was given. Endometrial biopsy at 12 months shows hyperplasia without atypia. That means it has not regressed to normal. So any type of endometrial hyperplasia which has not regressed to normal by the end of 12 months. Atypia became without atypia, but it did become normal. Regression means it has to come back to normal. So after 12 months, if the hyperplasia still persists, is also a candidate for surgery. Okay, so this patient will undergo the surgery of her hysterectomy, and because she is premenopausal, so bilateral salpingectomy will be done. 56-year-old lady is on tamoxifen, means breast cancer survivor, postmenopausal bleeding, found to have multiple polyps. Endometrial biopsy shows hyperplasia without atypia. LNG was inserted after. Definitely, LNG IUS in these patients are given after consultation with the oncologist. So if it is inserted, what will be the next step? We will do without atypia. We do a follow-up after 6 months with endometrial biopsy. So endometrial hyperplasia without atypia, put LNG IUS. Do endometrial biopsy after 6 months. If 2 negative biopsies are obtained, you discharge the patient from follow-up. But if the BMI is more than equal to 35, or if she has been treated with the oral progesterone, after 2 negative biopsies, 6 to 12 months biopsies should be done. With atypia, if the patient presents to you, always hysterectomy should be done, even if she is a young patient. So in the patient in whom we are doing a hysterectomy, if she is postmenopausal with hysterectomy, bilateral salpingo-oophorectomy should be done, and premenopausal with hysterectomy, bilateral salpingectomy should be done. Okay. So next set is of SBS. So there is a 52-year-old lady with a BMI of 31, vasomotor symptoms and vaginal dryness, no significant past medical history, menstrual period 12 months ago. She wants to start over the oral combined HRT, and she wants to know the risk of VT over 5 years. So any patient in whom patient is not taking any HRT in general population, the risk of VT is 5 in 1,000 over 5 years. If it is estrogen only HRT, it is 7 in 1,000. And if it is a combined therapy, it is 12 in 1,000. A 54-year-old lady complains of having sex. During sex, she is having pain. The symptoms began about 8 years ago. It is worsened over last year. She has tried all sort of topical medications, but no, nothing has helped. Now, because she has done every medical management, topical medical management, now she's a candidate for oral osmifene. This is from the new guideline of NICE that any patient with the genitourinary symptoms after menopause, the first line of treatment is always a vaginal estrogen. If it is not helping, then these patients can be given vaginal prosterone, which is also a kind of dehydroepiandrosterone. If that is not helping, the osmifene can be given. Now, this is for the general population who is not a breast cancer survivor. For the breast cancer survivor, the first line of management is a non-hormonal moisturizers or lubricants. Okay. In these patients, along with the estrogen, you can use them, but estrogen is a first line. Now, if this is not helping the breast cancer survivors, then the second line is vaginal estrogen because it is very less harmful. So it can be used along with that. Or the third line, aromatase inhibitors can be used. Laser surgery has no role, guys. Okay, please remember, laser surgery has no role. 60 years old lady postmenopausal on combined HRT for vasomotor symptoms. Now 10 months now she complains of decreased libido. So she's already on combined HRT and is complaining of decreased libido now. Her BMI is normal, blood pressure is normal, and she's non-smoker. So the next line of management for this patient is a testosterone, but a gel. Okay, it is only a gel form of testosterone which is actually licensed and available in UK for the purpose of the decreased libido in the menopausal age group. Okay. And if the patient has not started any sort of HRT and she is presenting to you with the menopausal symptoms and a decreased libido, low sex drive, then better is to give her directly Tibolon, which has estrogen, progesterone, and androgens, 3 of them. 48-year-old lady, no period for 14 months, most concerning feels low mood. Tried lifestyle modification and CBT, which has not helped her. So any type of depressive symptoms, which are not exactly depressive symptoms, but presents with the lower menopausal age group, please remember the best line of management is a continuous combined HRT therapy for them. This patient, according to the newer guideline, you always consider for depressive symptoms, even if they do not, usually when they are not meeting the criteria of depression, that means they are having a low mood, consider CBT as a first line. Consider HRT as a first line, sorry. Consider CBT as an option in whom vasomotor symptoms are present, and either in addition to the ongoing management, or in whom the options of HRT is a contraindication, or for those who do not want to try the HRT therapy. In case of severe symptoms, severity of assessment, if it's a major depression and this is not meeting the criteria of depression, but if it is a depressive case, then for major depression, first line is antidepressants and second line is HRT alone or HRT with antidepressants. For the minor depression, HRT as a first line with or without antidepressants, and for second line, you can just wait and watch, or you can add antidepressants or CBT. Okay, these are basically for the low mood patients who are not meeting the criteria of depression. So low mood, first line of management is a combined HRT, continuous combined HRT. 60-year-old lady with the abdominal pain, USG shows a right ovarian cyst of 4 cm, which is bilocular. Septa are present, which is a complete septa showing a bilocular ovarian cyst, and CA125 is 30. So what is the next line of management for this patient? Because this is a postmenopausal lady and the cyst size is bigger and also she has symptoms. So though the RMI is less than 200, so RMI in this patient is not 0. Okay, bilocular state, you always give score 1. So ideally she has a score of 90. Then also it is less than 200, but she's symptomatic in the cyst size because she's symptomatic. Though the cyst size is less than 5 cm, but she's symptomatic. For symptomatic cyst, we always offer them treatment. 60-year-old lady complains of abdominal pain. She has 6 cm ovarian cyst, bilocular, CA125/40. What is the most appropriate management option? So as I've already told you, here the RMI score will not be 0 because it is a bilocular. We score 1. For postmenopausal, score 3 and CA125 is 40. So 3 into 1 into 40 is 120. Now, because she's symptomatic, you will treat her. Okay. But the most important question is where you will treat her, because they are given various centers over here. So where do we treat her depends upon the RMI score. If RMI is less than 25 by the general gynec, 25 to 250 cancer unit by lead clinician, and more than 250 at a cancer center. So because here the RMI is 120, so she'll be treated by the lead clinician at a local center. So this is a 32-year-old, 6 weeks pregnant patient who has a ovarian mass, which is giving a ground glass echogenicity. Might be it is an endometrioma. They are saying that it is a dermoid. So what is the next step in our management? So usually patients who have in pregnancy, it's a repeat scan in 2 months which needs to be done. Now, whenever there is an adnexal mass in pregnancy, which is an acute abdomen, you do a surgery. If it is an asymptomatic benign mass, less than 5 centimeter, you do not do anything. If it is more than 5 centimeter, or if it is a complex mass, you rescan in 3 to 6 weeks, 4 to 6 weeks. Okay. So in this patient is a complex mass, so we can't leave her, but we have to do a rescanning in 4 to 6 weeks. If it resolves, is good. If there is no change in size, then 6 weeks postnatally we'll see to this patient. If there is any suspicion of malignancy, then the higher imaging and blood markers, tumor markers need to be done. 14-year-old lady who is having no menses and experience a growth spurt at 11. Breast and hair development began approximately 3 years ago. No further medical condition and no medication. She is not sexually active, no cyclical pain. Everything seems to be normal with respect to breast, pubic hair, appropriate height, per abdomen normal. Local examination is normal and uterus is palpable on per rectal examination. What will be the next step in her management? Now, because this patient, when you look to this patient, it seems that, first of all, you need to know what is the diagnosis of this patient. Okay. Why she has come to you? Because according to her age, she did not have menses, but her secondary sexual characters are well developed. So for the patient who do not have menses, if they are more than 14, no secondary sexual characters and no menses are there, or if secondary sexual characters are present but menses are not there and she is more than 16, or if menarche is not achieved even after 5 years of thelak, then she is a case of primary amenorrhea and requires an investigation. Because here the patient is 14 years and well-developed secondary sexual characters are there, just waiting for menses, it's a normal case. Okay, so she requires no treatment over here. Patient is suffering from lesions of vulva and scapula and that is not responding to steroids. So most likely these lesions are psoriasis, and when they are not responding to the first line management, then usually the second line management, calcipotriol, is the treatment of choice for the psoriatic patients. 6-year-old girl with a vulval irritation, redness, itching, staining of undergarments and greenish discharge. What can be the cause? So in young girls, the most common reason for the vulval irritation and itching is non-specific vulvovaginitis. However, if there is a persistent itch, constant itch, when there is a staining of undergarments, greenish discharge, it puts her at a risk of foreign body. Okay. So you need to investigate her by vaginoscopy. Okay, so thank you so much. This was from General Gynae module. Important questions from my side. Hope this helps everybody. Thank you so much and have a nice day. Thank you.